So it's 3 o'clock already, and I greet you all and I welcome you all back to today's class. I believe we are all doing fine. 5:30.
Yes, by the grace.
Okay, thank God. So just as our culture is for every week on Wednesday at 3 p.m. we meet to go through pathology. Go through pathology 1. And today wouldn't be different from the past 2 weeks. Okay. So just as we've been doing, you are going to recall that we are building the knowledge step by step. We are moving gradually. We are in anatomy and physiology. We are now on the tissue level. We have passed the cellular level. Now we are on the tissue level. Today in pathology 1, we are going to go through some cellular pathological processes and how these present themselves clinically. So that's what we are going to do for today. Our attention is going to be drawn to the cells, even though macroscopically we are going to look at the tissue or organ, but our principal focus is going to be on the cells. And that is what we are going to do for today. It's possible we can close in 30 minutes time. It's also possible that 3 hours will not be sufficient for us based on how fast we are able to assimilate all that we are going to teach. As you have come through into the main regular school, as we are progressing, I would plead that as much as possible, we try and then come to class on time so that we can get going, because it is getting tougher and tougher each time. And once we pass by a topic, it may be difficult for us to be able to understand. Okay. So that is it. Yeah. So let's see. Today it's Wednesday, so let's see what we have for today. Now, in lecture 3 for pathology 1, our focus is going to be based on 4 areas. 1, at the end of this lecture, we should be able to explain reactivity of cells. We should be able to explain reactivity of cells. second thing is that we should be able to describe cell adaptation and compensation. We should be able to describe cell adaptation and compensation. Thirdly, we should be able to explain the main adaptive mechanisms of cells. We should be able to explain the main adaptive mechanisms of cells. And then finally, for today, we should be able to explain these are four areas we are going to look at for today. As I said, they are just four, so you can just go to her by 30 minutes, we are done, based on the rate we are able to understand. Now, what is reactivity of cells and by extension tissues? Reactivity of cells and tissues. As the name suggests, reaction of cells. Okay. So we are saying that it is the morphofunctional transformations. Okay. The morphofunctional transformations of cells. Okay. Morphofunctional transformation of cells in response to external factors. Now, it is the response by cells in which the shape, morphology, and the function of the cell is transformed. Okay, that is reactivity of cells. When cells encounter external factors, and because they have encountered external factors, there are transformations in their shape, or there are transformations in their morphology or their structure and their function. Okay, so the morphofunctional transformations in cells or of cells when they encounter external factors. Okay, so we are saying that to reactivity of cells belong changes in the main regular aspects of tissue development. So just as we said that morphologically and functionally there are going to be transformations, these transformations are tailored towards the regular aspects of tissue development. For example, when cells react to external factors, okay, this can affect their proliferation or cell division, the rate at which the cells divide. It can also affect their differentiation, okay, especially when it has to do with stem cells. We've learned this, especially when it has to do with stem cells, okay, being able to pick up the role of other cells. It can also affect cell integration, okay, cells' ability to get on board, okay, and then how they interact. So there are intercellular interactions and other regular processes of histogenesis. Okay, so all that we are saying reactivity of cells is that the cell can encounter external factors. For example, when a cell in the body, let's take for example the cell in the lung. Okay, so cells that make up the lung, you inhale a poisonous substance. That is an external factor that has hit the cell, and there are going to be transformations, and these transformations can affect their function. It can also affect their shape. Okay, so that is what we are saying reactivity of cells and tissues are. At this point, any question?
Oh, carry on, sir.
Okay. Now we are done with cellular reactivity or reactivity of cell. Now let's look at a concept in pathology called adaptation and compensation. Adaptation and compensation. What is adaptation and what is compensation? Now, we have just looked at reactivity of cells. Now, if the cell encounters external factors, it must react. The reaction of this cell can be seen as being adaptive. It is either adapting or compensating. It is either adapting or compensating. Now, let me explain. Cellular adaptation, okay, we say, is a general biological concept that brings together all the vital processes that underlie the body's interaction with the environment and to preserve the species. That is adaptation. It brings together all the vital processes that underlie the body's interaction with the environment and to preserve the species. All that adaptation is talking about is that the body can encounter a foreign body. The cell can encounter a foreign substance, okay, or an environment that is unnatural to it. And once they encounter it, if it is unable to cope, then it has to adapt. And this adaptation is done by the cells to preserve the integrity of the cell and to make sure that the cells do not die. That is adaptation. So all the processes that are needed to preserve the life of the cell, even when the stressor or anything is impeding or impounding on it, that is adaptation. Now, compensation. Compensate. The difference between adaptation and compensation is simple. For adaptation, the cells have not been injured yet, and it is struggling with all its might not to be injured or die. In compensation, there are injuries to the cells, and the injuries to the cells have already happened, and the body is trying to protect the injured cell from further harm or dying off. Okay, so this is the basic difference between the two concepts: cellular adaptation and cellular compensation. Now we are saying that adaptation to changing conditions takes place by compensation. Okay, just as that have already come, and the body is trying to adjust so that it does not end up in further injuries that may be irreversible. So, okay, before we go on, is there any question for me?
Sir, good afternoon.
Yes, sir. Please, can you go over the compensation again?
Yeah, can you please go over for us?
Okay. Okay. So we are saying that for the past weeks, we have been focusing on the cells. We have been focusing on the cells. And I think last week we considered cell injury. Cell injury. Now, what we are seeing today is if a foreign body, if something that is unknown to the cell, if something that is harmful to the cell gets on board, what is the response of the cell? What is the response of the cell? If the cells are not injured yet, if the cells are not injured yet, but it is preserving with all its might the life that is within it, so that it makes sure the cell do not die. That process or concept is called cell adaptation. It is called cell adaptation. Now, for compensation, the injury to the cell might have come or must have come, and the cell is trying to preserve further injury or irreversible injury or death. Okay, that one becomes compensation, cellular compensation. Okay, it becomes cellular compensation. Okay. So at this point, is it okay, or I should go over?
So please, it's okay.
Okay.
Sir, the compensation. Okay.
The
Sorry, just
compensation.
sorry, go ahead.
Please, sir, you can go over again. I beg you.
Okay.
Sorry, before you do that, please, can you just show the first slide again for what we should know, what at the end of this we should know. I was just jotting it down, please. Thank you.
The outline.
Yes, please. Thank you. Thank you.
All
Correct.
right.
Okay. Thank you.
Okay, so we can go.
Yes.
Okay. So we are talking about a certain concept, and that concept has to do with the cells, okay, with the cells, biological cell, not prison cells, no, biological cells. And that biological cell is always undergoing stresses, okay, just as we've learned last week. It is always undergoing stresses. So our environment, whether in our environment, whatever we are doing, our cells are going to suffer a little because of the things we do. Okay. We inhale smokes in the environment, our lungs have to suffer. We do whatever we are doing, our our bodies, our cells are responding, whether they are responding positively or whether they are responding negatively. Now, sometimes when the cells are responding negatively, it's most very good. Yes, exercise. It likely means that the substance that is impacting on the cell, okay, is unnatural to it. So the cells must, because the cells are alive, they are alive in the cell is intelligent. The cell must choose one of these concepts. Now, the body doesn't permit the cells to die like that. The cells won't die like that unless the stressor, the substance that is affecting it, okay, becomes more than the strength of the cell. Then that cell will die. Now, the resistive power of the cell against the environment, whatever is afternoon, how are you doing? Okay, so the resistive power of the cell, okay, is what we are going to look at. Adaptation, the concept of adaptation is that the cell is encountering a problem. Whatever the problem is, whether it is an infectious agent, maybe a virus or a bacteria or something, okay, is trying to disturb the cell, or the cell is starving. The cell is starving. It's not getting nutrients, whatever it is. Okay, so all these things can become stresses to the cell. And the cell, before it finally gives up, it must adapt. It must adapt. Now, during adaptation, the cell is trying to make sure that it doesn't die or it doesn't encounter injury, even though there's a stressor against it. Okay, even though there's a stressor, there's a factor that is warring against it. Okay, so it must adapt. And that's the concept. So the cell marshals all the vital processes within its might to resist death or injury. When that happens, then you say that that cell is adapting, or that is cellular adaptation. That's the meaning of cellular adaptation. Now, when you come to compensation, with compensation, the cells have been injured already, and it is trying as much as possible not to allow the cells to die. That one becomes compensatory mechanism, cellular compensation. Okay, so now let me give example. Let me give example so that you can understand. Let's say you step on a nail or a sharp object, and then you get injured in your leg or in your feet. What is happening is that the cells, the cells that are there where the sharp object are, you did it yourself. Okay, don't change yourself. When you finish, you will do it. Okay. Okay. So when you step on the nail, you get injured. You get injured. Okay. Now the injury has come. The tissue under your feet, okay, your skin, your muscles, your fascia, even your blood vessel have been injured. So the injury has come, but the body is trying to make sure that further injury does not result. So it will now cause a process called inflammation, so that to cause pain there, so that you don't step on it. Because if you continue to step on and injure this one, the injury is going to be more and more and more, and the cells there will begin to suffer and then die. So one of the compensatory mechanism in there is that your body must cause something. It must cause pain, inflammation, pain there, so that you don't step on it. You get it? You don't step on it, and then the thing will die. That is what cellular compensation. The cells are compensating. Okay. When it comes to adaptation. Now let me give example like paralysis. Okay, paralysis. Now you can realize that there are some individuals on the street. They have lower limbs. Their lower limbs are paralyzed. They can't walk, and because they can't walk, they are unable to what? They are unable to okay, good. They are unable to what? Get the body to do what it does, especially the lower limb. As soon as the body realizes this now, it makes sure that the cells in the muscles of the leg, all the cells that make up the lower limb do not die easily. Okay, so it will try and then shrink the muscles in there. What? Really, come and give it to me. You will eat it. I come to show it to me. Okay. So you realize that the muscles in the lower limbs of that person, because it is not being used, okay, because it is not being used, there's a tendency that it will die. Okay, because it is not being used, there's a tendency that it will die. Because it has the tendency to die, the body must act fast. And what it does is that it tries to shrink the muscles that are in there. Okay, displace a lot of the unnecessary things in the cells, so that all the cells begin to shrink. So realize that these individuals, their legs have become very thin. Okay, and it is an adaptation strategy of the cell, so that the cells do not die. So this is what the body actually does. Okay, as and when there is there's a factor, there's something that is affecting the cell. Okay, so that is what it means when we say cellular adaptation or cellular compensation. Have I succeeded in confusing you them all? Any question, suggestion, contribution? Okay, it means we have all understood. The way the class is quiet, we are seeing
We are
stuff.
with you. We are with you. We are with you.
Okay, thank you that you are with me.
We are following. We are following.
We thank God. In fact, we are now gradually. We have now been able to walk gradually to the riverside, and now we are getting into the river. So we have started stepping into the river. So it will get to a time that we have to dive and get deeper into the river. And then if you have not tied your rope at your waist against a tree, then when you dive, you may likely not come out. If you have tied a rope against a tree before you dive, then okay. And then that you being able to tie the rope at your waist against a tree before you dive is the preliminary stages. Lecture 1, lecture 2, lecture 3. So we are on lecture 3. So you have to read so that you are able to tie the rope well. Other than that, soon the river will take you away. Okay, Mr. Kwesi. Mr. Blessing. Your hand is up, or is a mistake? Okay. Looks like it's a mistake. Now let's go on. Now that we have understood what adaptation and compensation is, we are now going to take a step further. I told that this is only 29 slides, so we can finish in 30 minutes, but we can also remain here 3 hours. We wouldn't have finished. So adaptation. Let's look at how adaptation appear by different pathological processes. Okay, how adaptation appears in different pathological processes. Now, you can find adaptation appearing as what? Atrophy. Atrophy. Okay. You can find adaptation appearing as hypertrophy. Hypertrophy. So you are going to understand a lot of the terms that doctors use when they are describing diseases. We are now entering. You can find a term or pathological process relative to adaptation called hyperplasia. Hyperplasia. You can also find one called metaplasia. And finally, one appears also as dysplasia. So the adaptation mechanisms may appear in any one of these pathological processes. In compensation, you can get it as what? Compensatory hypertrophy. Compensatory hypertrophy. Okay, let's take them one by one. Cellular atrophy. What is it? Cellular atrophy. What is it? We are saying that cellular atrophy is a lifetime decrease in the volume of the cells, tissues, organs, and it is accompanied by a decrease or cessation of their function. Understand this. It is a decrease in the volume of the cell or the tissue or the organ, which is accompanied by a decrease or cessation of their function. So you can understand why persons, as I was explaining, those who are on the streets and they have paralysis of the lower limb. Okay, you can understand they have atrophy. Atrophy have set in. Why? Because they are not using them. So any body part that you don't use, as time goes on, it will atrophy. If you really want to experiment, just get something to tie your hand against your chest, maybe your left upper limb or the right upper limb. You just put it on your chest, one on your chest, and tie it against your chest for 6 months, and begin to see the volume of your hand decreasing in your face. If you don't use any body part, it atrophies. That is the principle of the cell. Okay, so cellular atrophy is the lifetime decrease in the volume of the cells, tissues, organs. Okay, and it is accompanied by a decrease or cessation of their functions. Okay, it is when it ceases to function, then you are there. Any question? Okay, looks like I saw a hand, but it's gone. Okay. Now, when you come to atrophy, yes, Mr. Apia.
Yeah, hello. Yeah, sir.
Yes.
So does it mean, let me put it this way, those who, or let me put it, some people faces shrinkage of their body part, especially, let me put it, for instance, their penis. If it shrinks, is it as a result of atrophy? Sometimes I know there are other causative agents. Can that also be classified part of it?
Yes. So it is an adaptive mechanism. Okay. And that adaptive mechanism, the thing is losing its volume. The cells are shrinking, the tissue is shrinking, the organ is shrinking. We all know that the person's langa, the langa was this big, and then time goes on, and then the langa is become small and small like that. It is atrophy. The causative factor can be different. That the person is chaste or is practicing celibacy, and that is it. It can be, or the person has gotten some infection, and that infection, the body is trying to what make sure infectious in the.
Come again, sir. You said something celibacy. Hello, sir.
Yes.
Sir was
sir, I
saying
didn't quite catch that. You said, yeah. Okay, celibacy. Okay.
I really want to get your question well. Okay, maybe by the time I'm done. Now, what I'm saying is that can you hear me?
It's breaking
Yes,
The
up.
we can.
class hear me? It's breaking. Okay. Please, at any point in time when you prompt me, sometimes the network can be. So, what am I saying? Yes, with regards to the penis, the langa langa, a man's property. You know, when it is not in use, okay. I mean, the more you use it, the bigger it becomes. That is natural. And by this, I'm not saying that go and be chasing women. No, I'm saying that the more you use, the bigger it becomes. The less, it becomes smaller. Okay, that is one principle. But there can be other factors that is causing the shrinkage. If the person is sexually active, but the thing is still shrinking, then you can't say it is not the because the person is not using it. The person is active, so it may be an infectious agent that is causing it, and that infectious agent, the cells that makes up the penis, the langa, the almighty timber, the cells that make up the penis, okay, is trying to adapt so that this one does not cause any injury to it, and that is what makes it shrink. Okay, until you are able to take the stressor, the pathogens away, then the cells will feel free and then come back again. Okay, sometimes it can be that. Okay, sometimes it can be that. Sometimes it can be genetic. I mean, sometimes, the lifespan of the cell. Sometimes the lifespan of the cells in the penis, if you are supposed to last maybe for 3 months or 4 months, sometimes genetic it can be dying faster than this one, and then to be shrinking. So a lot of things can but whatever it is, once it is shrinking, it is atrophy. Why? Come and sleep. Okay, is it okay? Madam.
No. Yes. Okay. Respectfully, sir, I would like to really. I don't agree. Okay, I'm not a man, but I'm just thinking of it pathologically. Is this applied in terms of an injury or some abnormal setting in the man's life? Not just that he's not having sex, so his langa gets small. Because one has to be careful so that because people do walk around talking about they need to use their langa so it doesn't get small. Or another famous one is that so that they don't get prostate cancer, which I do know people who have practiced that and still get prostate cancer. So, but seriously though, is it because lack of use because of an injury, like being in the hospital for some time? Because I see men who are not in their right minds on the road, and their langas, not small. So I don't know if they use it somewhere, but on a very serious note, is it just it atrophies for lack of use, voluntary lack of use, not that they're in the hospital or they're sick somewhere. I'm trying not to laugh, so please stop sending those laughing things. But I'm being serious. Really, I'm being serious. I'm not. I'm not being funny, because it's something I have had to deal with. People talking about they have to have it plenty because they don't want, certain things. But is this because of some injury or some involuntary lack of use? Not that they can, but they just don't do it. You understand what I'm trying to say? And I don't know if there's any evidence of langas getting smaller because of lack of use. But I see, these men on the road all the time naked, and they don't look small to me. So
Yeah.
yeah, but it's a
So
serious question.
yeah. So what we are saying, the question one of your colleagues asked is that shrinkages in pennies. Okay. Shrinkages in pennies. Is it also atrophy? And we are saying that yes. Okay, yes. Any body part that you don't use, the principle is that it shrinks. Any body part that you don't use, it shrinks. That is one principle. The next is that the question was, if could it be that the person is not using it and it can cause the shrinkage? Yes, because the principle is that if you don't use it, it shrinks. But it is not only when you are not using it that it can shrink. There can be other factors. Okay, there can be other factors. Okay, that can contribute to it. And we are also saying that. We are also saying that the fact that the person is not using. Okay, or how do I even put it?
Voluntarily.
Yeah, there can be the situation that it is not always that you can see a shrinkage in the pennies that it is so noticeable. Okay, no, in fact, normal atrophy, if you really, really want to get atrophy that is very, very observable, it is going to be quite a long time. In fact, you can take notice of your patients who are involved in RTS and then they get paralyzed. Okay, they
Right.
get paralyzed.
Yeah.
Once
Yeah.
they get paralyzed, it doesn't take 1 month or 2 months for the
Yeah.
legs to start shrinking. It can take
Mhm.
sometimes 5 years. Okay,
Yes.
but these are physiological processes that the body undergoes just to preserve the integrity of the cells. Okay, so yes, a man
Like
can be
stroke
there.
people, stroke patients.
Mhm.
Because,
Yeah.
under normal circumstances, men physiologically, their bodies do involuntary things, even if they're not active, in the morning or sometime they do things, their bodies do things involuntarily. They don't
Mm,
wake up in the morning and voluntarily, So
mm,
even though they're not doing these things on purpose, their body is being active. I can see with
mm,
a woman who is celibate, I can see that. But for a man, I just think that is a stretch.
yeah. You know, and,
Am
and
I
and it is understandable from your side,
Yeah.
because the measurement the man was having 5 years ago and the measurement the person is having currently may not be something that you may be able to really
Oh no,
really.
no, no, no. You have old men
Mm,
who are active, who
mm,
are they just like from long time.
yeah. So that is it. But for atrophy to be really really visible, okay, for atrophy to be really really visible, it has to take quite a longer time. The body doesn't, I mean, shred off or shrink. The cells do not shrink immediately, like maybe a month or two. No, it has to take quite a longer time. Okay. There's someone saying breast also shrinks. The body, once you are not
second?
using it, yeah.
Can I share my thought?
Yes, please share your view.
Oh, okay, thank you very much, sir. About the question she raised. You see, one thing about madness, and when it comes to, voluntary celibacy, when it comes to normal people, normal men, is that
Mm,
the moment you decide to become celibate,
mm,
testosterone levels drop, and dopamine levels equally will drop because you are not exercising your sexual rights. You see, one thing that helps men to really produce a lot of dopamine is the sexuality. If you can express your sexuality well, your dopamine levels goes up. Yeah. But if you become celibate and dopamine levels go down, depending on your constitution, it's possible that your feelings will be atrophied. About mad people, you know that a mad person's emotional threshold is not in place. And usually when a man goes mad, he goes off, the dopamine levels keep rising. So it is not a surprise that a madman will still have a large langa, a good langa, and still walking around. Whereas a celibate normal man will have an atrophied langa. So that is just.
Okay. So thanks for giving us insights. Okay. So Mr. Diodu.
Yes, sir. Good afternoon, sir.
Afternoon.
Yes. Daddy, please, what you said is true. I do remember I gave my life to Christ very young. And up to 40, I wasn't married. So one day I fell sick and I went to hospital. And the doctor told me categorically that my penis is shrinking. And I said, why? And he said, it seems I'm not married. I said, yes. And asked me why. And I said, I've decided not to marry because of the work of God. And he told me that it will be a time that if I'm not married, my penis will shrink. So what you are saying is true. There's no doubt about it. The woman, what he's saying, because he's not a man, so he is applying what is happening in the hospital. But me, I'm talking about my personal experience. So because of that, I need to get married. Because doctor made me aware. Do you understand? Because I was there getting to 45 years and still, I decided not to get married. And my penis began to shrink like a year, like 5 to 10 years. So what you are saying is perfectly true. There's no ambiguity about it. There's no doubt about it. Thank you, sir.
Yeah, thank you. If you don't use it, you lose it. Mr. NBTV, is it a woman or a man?
Yeah, I'm a man.
A man, okay.
I just want to make this contribution. You see, when it comes to not using it atrophying without being used, I don't think that one is much of a problem because the penis is just like our muscle. If you do not exercise or train the muscles, it will not expand. But if you train it, it will expand. But those who are not training and their muscles are not expanded, it's not much of a problem. But when the atrophy is due to some infection or some kind of ailment, I think that one will be the problem. If it is
Yeah,
because of non-use, that is why it is shrinking. I think that one you can revive it. If you start
yeah,
using it, to come. But when it becomes
yeah,
an infection or something, that one, I think that one is the problem that we are looking at.
yeah. So yes, so that's the truth. That's the plain truth. And it is a normal. Why should the body send blood to the penis when the body needs more blood in the stomach or in the liver or on this one? Then send it to the penis. Then to jack. Not it is not getting anywhere to do. Then no. The body doesn't operate that way. Okay, the body doesn't operate that way. So that is how it is. But whatever it is now, individual differences too will come in. There are some people, their body parts, the atrophy would be minimal. Some too will be very minimal. So it depends. It depends. Okay. Now, is there any more question, suggestion, contribution before we can move on? Okay. So now let's go on. We are talking about atrophy. Okay. Now, atrophy, wasting, shrinkages of cells, tissues, decreasing in their volume can occur on two fronts. One, it can be a physiological atrophy, and it can also be a pathological atrophy. Okay, just as we are saying, just as our brother said, if it is a physiological atrophy, there's a likelihood that it may not be a problem, but pathological atrophy will now cause for a concern. Let's dive deeper into it. Now, physiological atrophy, we are saying that, yes, question.
Na ha na obedi ado. Me kwa na ada na wanka. So na me se me kwa obi. Ada
Who
na
is that?
wanka ho asa. Do ya bra ho.
Madam Dr. Sasana, please, your microphone.
Ah. Okay.
Okay. Thank you. So, physiological atrophy, we are looking at atrophy. Now, let's look at the physiological atrophy. We say physiological atrophy, we can see it in the general atrophy or senescence atrophy, and then evolutionary atrophy or local atrophy. Let's look at it. When it comes to physiological atrophy, we are saying that in general atrophy, there is a sharply reduced amount of adipose tissue depot. Sharp.
75.
Oh, Madam Docas.
Wait, Madam Docas.
The best thing for you to do is to put your mic on mute when you want to talk.
Sir, can you meet here? Can you meet here for us?
No, I'm not the one in control of this one. The link.
Madam Dr. Sasana, please, your microphone. Madam Dr. Sasana, please, your microphone again. Or the phone not to be you.
Please, the one controlling the distance should mute him or remove her.
It's supposed to be Madam Tena, so, and she's not on. You let me call her to join as the host and then remove her.
Okay, it looks like she has gotten it. It looks like she has. Okay, great. So yeah, so that is it. Now, so we are saying that for physiological atrophy, there are general and the local. The general ones, the adipose, the fats that is in the tissue, okay, is reduced sharply. Okay, it disappears like that. And you know, when fat disappears, when fat is tissue, shrinks off, then that particular tissue or cell will shrink immediately. It becomes very sharp. Okay, it becomes very sharp, and you are able to notice it. Okay, so for example, the internal organs are reduced. The liver, the heart, the skeletal muscle, okay, all of them are reduced. And what do? They take on a brown color due to the accumulation of a golden pigment called lipofuscin. Okay, so usually that is how it does. So it becomes very fast, and it is generally done this way. The body generally does it this way to preserve the integrity. Other than that, something bad can happen to the tissue. That is for the general or senescence atrophy. Okay. Now let's look at when it happens in the. Okay. So I'm going to do something small and my prepaid is finished. Other than that, the laptop will go off. I'm going to put some on it and come. So now the class, let's try and take this disease conditions. Okay, everyone should pick one. Okay, let's try. I mean, we are many, so let's try and then pick one so that as soon as I come and then we are going, you mention it and then we discuss. Okay, I'm going to do some small work and come on my prepaid.
Hello?
Yeah, we are there. We are all here.
Okay.
We can't hear anything.
The lecturer has gone for a break. I mean, he will be back soon.
Also, we were assigned to select one of the bullets and see if we can elaborate on them when he gets back. That's my understanding.
Sorry, say that again, please. I missed something. What did you say? Please, Sister
Before he
Olivia.
left, he assigned us to select one of the bullets that are on the slide, and we would give a comment on that bullet. What it is, I
Yes.
guess, I'm researching it, what it is and how does it describe the atrophy, the form of atrophy. That's my understanding. Correct me if I'm wrong.
Yes. So thank you. I'm back. Let me plug the laptop before. So we are looking at atrophy, and we are saying that for atrophy we have physiological atrophy and pathological atrophy. Physiological atrophy and pathological atrophy. Okay. Now, for physiological atrophy, we are looking at how this atrophy appears in some parts of our body. Okay, and what we most likely would see. So when we take the alimentary canal, okay, when physiological atrophy sets in the alimentary canal, we are seeing that it usually leads to malabsorption and maldigestion. Okay, so when you take these conditions, esophageal stenosis, okay, chronic enterocolitis, and celiac disease, these conditions have physiological atrophy underpinning them. Okay, underpinning them. It may be the pathogenesis may be different, but you have physiological atrophy underpinning each one of this. For psychogenic conditions, you have condition called anorexia nervosa. Anorexia nervosa. Okay. You can also have what we call cancer cachexia. Cancer cachexia. So someone gets cancer and then the body becomes atrophies. Okay. Then we can, for disorders of metabolism and endocrine disease, we can have Sheehan syndrome. Sheehan syndrome. We can have panhypopituitarism, or what we call hypothalamic pituitary insufficiency. Okay, panhypopituitarism. We can also have a disease called adrenal insufficiency, and also insufficiency of the thyroid gland. So these conditions primarily have atrophy underpinning them. So I was trying to say that, if possible, we should try and then look at these conditions. Should they go? Should they go? Should they? Okay, then let's just look at one. Is anyone ready? Have anyone done research on any of them? If yes, then we can look at one or two then.
Okay, sir. Hello, sir.
Yes.
Coming to the psychogenic one, the anorexia nervosa. So this is a disorder whereby a person has something in mind that she or he will not eat because of some reason. Yeah. A person may feel to eat, but there is a certain, intention or something in mind that when he or she eats, he may become fat, or due to some conditions or some reason, he will not, eat. That is that one. So it is an eating disorder.
Psychogenic. And when someone does not want to eat, someone is not eating, the cells are unable to store excess fat. The person is not becoming fat. The person is always reducing weight. The person is underweight. Okay. And once you are not feeding the body with the needed nutrients that it needs, the how do you call it? The glucose, the fats that it needs to use and then store some. To maintain weight, you are not getting it. Then the cells will have no other option than to shrink. Okay, and that is what happens. Okay, so yes, that is it. Great. Mr. Samuel, have you also seen some, or is the question?
Yes, for me, I chose the esophageal stenosis.
Okay,
so is the abnormal narrowing of the esophagus, the muscular tube that carries food and the liquids from our mouth to our stomach. This is a hallmark of a condition of dysphagia, meaning difficulty in swallowing. And these are the causes or the common symptoms, like sensation of food sticking in the chest or throat, pain while swallowing, and regurgitation. Thank you.
good. So you see, the esophagus becomes stenosed. Okay, usually there's this expansion and then contraction that goes on, so that when you swallow your big banku and then it's moving through your this one, wherever the banku rate there, this one must expand. But in this case, it is unable to do that. Okay, and then it results in this one. These are all this one, the atrophy disease condition, that atrophy is in there. Okay, so that is how it is. Madam Olimide.
Yes, I had also selected anorexia nervosa, and I shared in the chat the name of a documentary that would be very useful, and it's called Dying to Be Thin. And it is something that is very dominant in ballerinas, people who are dancers, and and then that also goes along with bulimia, where they actually force themselves to throw up so as not to take in the nutrients from the food that is consumed.
Yeah.
So I had selected that one.
Yeah, Dying to Be Thin. That was great. We can all go and watch that documentary. It's not easy, psychogenic. Okay, so that's great. That's great. That's great. I believe we can
Sir, can you
go.
look at the celiac disease?
We can look at celiac. Okay, celiac.
The celiac disease. It's an interesting findings there. What I got was it says it's a chronic autoimmune disorder where the injecting gluten, which come from proteins in wheat, maize, and others, and it triggers the immune response that mostly damages the small intestine lining, specifically the villi.
Yes. So that is celiac disease. Okay. It's autoimmune nature. The body is not really receptive to some food substances. Okay, and then it has to do something about it so that it doesn't die. So physiologically, it has to shrink until that substance is able to get off the alimentary canal, and then it comes back to normal. Okay, so that's how it is. Yes, that's great. Pastor Henry.
Good afternoon to you and to colleagues. Yes, I looked at Sheehan syndrome.
Okay.
The Sheehan syndrome. And then it says that it's a rare condition that happens when the pituitary gland is damaged because of severe blood loss or very low blood pressure during or after childbirth. And it says that what is going on in the body, that during pregnancy, during pregnancy, the pituitary gland enlarges and needs more blood. And if a woman has massive postpartum hemorrhage, the blood supply to the pituitary gland drop sharply. And this causes ischemic nitrosis, death of pituitary tissue. As a result, the gland can't make enough hormones in hypopituitarism.
Yeah.
Hypopituitarism. So hormones commonly affected. So in short, this is what is telling us. It has more, but this.
Yes.
You can
so pituitary gland. Okay. There's a disease condition affecting it, and the cells must immediately respond. Immediately must respond, and in their response they shrink to refrain from death, and that results in what we call Sheehan syndrome. You know, Sheehan syndrome. Don't worry, they won't read pathology too. You understand a lot of things. Okay, any more? Other than that, we move. Okay. So these things. Yes, Mr. Samuel.
Okay, so I'm looking at the what's the name? The adrenal. Where is it?
Insufficiency.
The adrenal insufficiency. Yes. Like I've seen that when the adrenal gland, which is a small gland that is found on the kidneys, when they are not producing enough adrenal hormones like the cortisol and sometimes aldosterone, which affects stress or which makes it difficult for managing stress and maintaining blood pressure. So people with such conditions normally get low blood pressure, which makes it very difficult to be treated. And we have types. We have the primary, which is the Addison disease. It happens when the autoimmune response destroys itself. And we have the secondary one, which is the pituitary gland fails to produce enough adrenals or the cortisols to manage it. Thank you. So let me say the causes. Mostly it happens when we have persistent fatigue and muscle weakness, loss of appetite, and unintentional weight loss, and low blood pressure. Yes, and short craving. Okay, okay, okay.
Craving,
Thank you.
yeah, yeah, yeah. So that's true. So you see that all these conditions, irrespective of their pathogenesis or their pathophysiology, atrophy is in there. And this is done because the body wants to preserve the integrity of the cells. Okay, that is what is happening. Now let's look at cachexia, cancer. So you see, this is cancer cachexia. Okay, so sometimes you can okay, so sometimes it can happen like that. Okay, for example, AIDS would really struggle with the body. Okay, AIDS will really struggle with the body. The cells will have to dodge the AIDS, I mean the disease. Then, I mean, shrink. So that's what happens to AIDS. It's just that the cells are simply trying to what? I mean, survive the viruses, the HIV virus. Okay. And because of that, all these things will come in. It will get to a time the cells will not be able to what? Will not be able to stand because they have shrink and our nutrients are not coming. This one is not coming. Eventually, the person will die. Okay. So that is what happens. Yes, Madam Olimide.
Yes, does it mean, Doc, that the disease is giving off too much toxins for the body to handle, for the cells to handle? And that
See,
leads to
yes.
I'm trying to put it simply.
Yeah. So yes, so you are right. That one too is part. But basically, the cells are putting themselves in a position that they don't want the virus to attack it. Okay, they don't want the virus to attack it. And so when you try and then fight, at the end of the day, the cells wouldn't be able to get enough, I mean, survival, this one, like their nutrients, their water and whatever. Okay. And by, the cells will die off. Sometimes it is even seen that the virus does not really overpower the body. It's just that as the body is overly concentrated on the HIV virus, then another bacteria or virus will come and then kick the person, and then the person will die. Okay, so usually this is what happens. Normally, AIDS patient, you see the person dies of tuberculosis or something different. Okay, so that is how it is. Okay, can we move on? So now let's go.
Yes, Doc.
So yes. So now let's go on. Okay, so this is an example of the physiological atrophy, the general or senescence atrophy. Okay, so we realize that. Compare this leg and this leg. Okay, this leg is bigger than this. Okay, You see here is big. Here, this one. Okay. Or this one. I mean, the person is bedridden. The person is not using the leg like it should be walking on this one. So the muscles have shrunk. That is how it is. Okay, atrophy. So these are general atrophy. Mhm. All right. Now let's look at pathological atrophy. Pathological atrophy.
It's
Okay.
nothing
Okay.
showing here.
Yes.
Nothing showing.
So the person should check. Well, I can see sometimes when you see all images coming, and you need to press on the particular one who is presenting, and then maybe turn your phone to. You may get it if you are using a phone. Thank you.
Okay. Okay. Mr. Samuel.
Okay, so I was trying to ask the picture that you showed, the two legs. Is it not it in our communities? I think they have normalized this thing. Like everybody has the legs want to be bigger than the other, or I'm wrong. Like people will go to the market, they will use only one leg. When the leg is able to enter, they know the other leg can easily enter. Something like that.
Yes. So um yes, we know that usually by comparison, our legs or our hands, whatever it is, the size will not be the same, but it is not very, very observable. Okay, it's not something that is observable. But when it is apparent, like this one, then you know that there's a problem. Then you know that there's a problem. Okay, for this one, sometimes you can maybe when you measure, you may get maybe a circumference of about, let's say, let's get like maybe 5.11, and you can give you maybe 5.13. That is okay. But when you measure circumference of you are getting 5 and here you are getting 9, then that one is a problem. That one's a problem. Okay, so that is it. Now let's go to pathological atrophy. Okay, so pathological atrophy, we are saying that there are many kinds. Okay, we can have dysfunctional when there is no inactivity. Okay. Um, okay. So let's understand pathological atrophy in this way. Pathological atrophy, pathological atrophy is usually when the body tries to preserve the integrity of the cell from further harm, especially when injury has already set in. Okay, so you have a case or a disease condition or a state when the body is undergoing a process and the body feels deemed that it will try and then to try as much as possible to get the cells to maintain its integrity before it dies. Okay, so for physiologically, I mean, it does so when the cells have not been damaged, but pathological, it does so when the cells have already been damaged, but it is preserving itself from further damage. Yeah, that is how I want us to understand. So this is it. Like this is the brain has atrophied. Okay, due to ischemia. So there's no blood flow there, as it happens in stroke patients and all this one. There's no blood flowing in there. So the brain cells shrink, and then fibrous tissues come to what? Come to cover them to make the size look, I mean, the same. Well, as it has gotten here, it is going to shrink, 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 shrink. And then before you realize something bad has happened. Okay. Yes, as we have here. So this is the kidney. Okay, there's the kidney. So there's accumulation of water in here. It's destroying the kidney, and the tries to what? Kidney tries to atrophy. It tries to shrink so that it prevents this one from death. Okay, so this is it. Now this one is a dead person. Is this one? Okay. Okay. At this point, any question? We are done with atrophy. Any question for me before we go to the next? Okay. Now let's go. Now that we are done with atrophy, the wasting, the shrinkages, we are going to hypertrophy. Hypertrophy. Okay. Now, what are we saying hypertrophy is? We are saying hypertrophy is an increase in the volume or tissue of a cell, okay, or a tissue due to increased functioning structures. Now look at atrophy. For atrophy, the body part is not in use, and so shrinkages of the cell comes in. For hypertrophy, the body part is used beyond the normal. There's an increased functioning, and then the volume thereby increases. Okay, so the mechanism is simple. There is an increased volume of functional structures of specialized cells. Okay, there's an increased volume of functional structures of specialized cells. Then we have increased number of specialized cells. Then the increase is both the number and the volume of specialized intercellular structures. Okay, so we are going to explain this as we move on. So hypertrophy simply means there's an increase in the volume of the tissue or the cells. There are two main types of hypertrophy. Two main types. We have adaptive hypertrophy and compensational hypertrophy. Adaptive hypertrophy and compensational hypertrophy. Okay, let's look at adaptive. When it comes to adaptive hypertrophy, we have neurohumoral hypertrophy, and then we have hypertrophic growth. Okay, should I confuse you more? No. So not really. Not really. We'll come and see them. We'll come and see them. Should I confuse you more? Okay, so what you have to understand is that hypertrophy is the increase, okay, is the increase in the volume of the cell. Okay, usually for hypertrophy, listen, no, there's a difference between hypertrophy and hyperplasia. Hypertrophy, that body part has been increased, but there's no increase in the number of cells. Rather, the same cells, but their sizes have increased. Okay, but their sizes have increased. So look at this. So this is an endometrium. Endometrium, okay, which has increased in that number. You see that, I mean, it has become bulky. It is even reducing the space. Okay, the space here. So That's how it is. Okay. Okay, so for hypertrophic groups, we have like example like polyps. Okay, so for hypertrophy, you have adaptive and then compensatory. Some of the adaptive this ones are the hypertrophic groups, and then so polyps. You know polyps. I hope you know polyps. Okay, so they are there. Okay. Um, yeah. So someone is asking of a question about bodybuilders. So we are coming there. So now let's look at compensatory hypertrophy. Compensatory hypertrophy. For compensatory hypertrophy, there are three types. We'll focus on two. We have the working hypertrophy and then vicar hypertrophy. Let's see. Remember that hypertrophy is the increase in the size of the cell or tissue and not the number. Okay. So for working hypertrophy, we say it occurs due to excessive load on the organ, okay, requiring enhanced function. Okay, we are saying the most common work hypertrophy is cardiac hypertrophy. So you've been hearing a condition called left ventricular hypertrophy. Okay, those who are this one, persons will come to you with clinical reports. What is that clinical report? They say left ventricular hypertrophy, left ventricular hypertrophy. Okay. So what essentially means is that the heart is doing more work than it should be. And usually is because of what? Hypertension. When blockages in this one, when hypertension sets in, the volume of work for the heart increases, leading to what? Left ventricular hypertrophy. Okay. Okay. So you see this and then this, and then take a look at this portion where you have the left ventricle. Okay, it has swelled up. That's swelled up. Okay, so this is the working type. Okay, it's not that the person has increased in the cell; the cells have increased. Okay, but the sizes of the cells rather have increased. Okay, and the person has become this one like that. Man, look at what you have done to your body. It's not easy. Okay. Then we have one of the hypertrophy, one of the compensatory hypertrophy is the Vicar hypertrophy. Vicar hypertrophy, it usually occurs in the organs that are double in our body. Okay, like kidneys, lung. When one is injured, the other one must do double because of the one injured. The work doubles up, and once it becomes double, it undergoes hypertrophy. Okay, so vicar hypertrophy happens in what? Paired organs like kidney and then lungs. Okay. Okay. Any question for me for hypertrophy?
What about the adrenal glands too?
Yes. So adrenals too. Yes. So adrenals too are there. There are two. One destroys, one takes over. But the brain is going to force the one that is effective, the one that is working to do more work. Okay, to do more work.
And the eye too, the eyes.
Aha. So it's like that. So paired organs. That's how it is. Any question, suggestion, contribution for hypertrophy? Now we have looked at atrophy. We have looked at hypertrophy. We are going to look at the three remaining. And then by this, we would have said that we have really started pathology. Okay, so let's go. I know by now many are seeing stars. So now let's look at dysplasia. Dysplasia. Okay, dysplasia. Okay. Now, what is dysplasia? We are saying that dysplasia is characterized by impaired proliferation and differentiation of the tissues and cells with development of cellular atypia. Okay, so for dysplasia, you have impaired proliferation, impaired cell deviation, cell division, and differentiation. Okay, so there's an impairment there. Okay, and when this happens, when there's a development in the cellular atypia, you are going to see what different size and shape of cells. Okay, you are going to get different size and shape of cells. I want someone to research this word for me. An anisocytosis. Anisocytosis. And someone should also research this word. Poikilocytosis. So let's go. Tell me what it is.
So where are the spellings?
Oh, okay. Okay. So anisocytosis. So you are the anisocytosis. So anisocytosis. ANISOCYTOSIS. Anisocytosis.
Okay.
So can I read anisocytosis?
Yes.
So it is saying that anisocytosis means unequal red blood cells sizes seen on a blood smear. It is not a disease on its own. It is a laboratory finding that points to an underlying problem.
So you see, so dysplasia can occur even in red blood cells. And so you are having different sizes in red blood cell. They are called anisocytosis. Anisocytosis. Okay, how about poikilocytosis? POI.
It means
It
means that the red blood cells of varying shapes on your blood smear.
So you see, so sometimes your red blood cells also can have different shapes. Okay. So anisocytosis, they are having different sizes. Poikilocytosis, they are having different shape. Okay. And as by and by, we can look at why it is like that. So this is it. Dysplasia, you are having impaired proliferation or impaired differentiation. Okay. And it leads to different size and shape of cells, increased nuclei, and their hyperchromia. Okay, sometimes you can have these conditions appearing. So another thing is that we have the increase in the number of mitosis and atypical mitosis. So for the rest, I think you understand. Loss of epithelial polarity, loss of histological and organ specificity, violation of tissue component ratio. So dysplasia, understand that it is characterized by impaired proliferation. The cells that are dividing, there's problem with it, or the cells that are supposed to take over and then do the work of cells that are dying, the stem cells that are should take over cells that are, there's an impairment there. Okay, either there's a problem with the ship, either there's a problem with the sizes, either there's a problem with their nuclei, either there's whatever it is, there's a problem with the cells. Proliferation, differentiation, and dysplasia results. Okay, dysplasia results. Any question for me before we move on? Yes, Mr. Samuel.
Okay, so I read some, let me say, an article, and it was saying this dysplasia is a precancerous condition. Is that it?
Yes. Yes. So you detect it early. You look at the conditions that are affecting it and then solve it fast so that there's no problem for you.
So, sir, please, hyperplasia and hypertrophy are the same, isn't it?
No.
Okay.
So hypertrophy, there's an increase in the sizes of the cell or tissue, whatever. With hyperplasia, there is an increase in the number of cells. The sizes have not increased, but their number have increased. I hope you get the difference now.
Yes, sir. It's okay.
Madam Olimide.
Yes, thank you. Thank you for acknowledging me. What about sickle cell anemia? How would that fit in this? Would it be a form of the anisocytosis, or tell me, please?
Yes. Sickle cell conditions can be quite different. With this one, we are looking at adaptive processes. Okay, there are different types of adaptation that we have. For sickle cell, it's a disease condition. Okay, it's a disease condition. It is not really created with the purpose of adjusting itself towards a particular condition. It is a condition itself. Okay, adaptation we are looking at is that the processes that occur so that the body is able to withstand a disease condition or withstand a foreign body. Okay, but for sickle cell, it is a disease on its own. It is a malformation on its own. Yeah. Any more questions on dysplasia before we go to metaplasia? All right. Now let's go to metaplasia.
Hello, sir.
So yeah, yes.
Yeah, sir, can dysplasia be managed? Can it be managed?
Can what be managed?
Yes, since the cells keep on proliferating, can it be managed?
Yes. You know, when we are able to get away the stressor, the body would naturally return to normalcy. Okay, the body, but when the stressor is there, if it is maybe a deficiency, maybe it is a pathogens, it is the bacterial virus or something that is causing it. Maybe it is whatever the thing is. Once you're able to get that thing off, the body would bounce back.
I see. So can we say acid reflux is dysplasia?
Acid reflux.
Yes, esophageal reflux. Let's say it like that.
Acid reflux. I'm not sure because for acid reflux, the valve, okay, the sphincter, esophageal sphincter, is what is weak and making the stomach acid bounce back into the esophagus. So that one may not necessarily fall within dysplasia. Okay. In fact, it has even become weak. It has even become the sphincter has even become weak. So it is rather a disease condition. It's rather a disease condition. Okay. So what we are talking about adaptive, this one is that something is about to happen to the cell, and the cell is trying to, do something so that that thing that is coming is not able to overpower it.
You're not hearing anything.
Okay.
Okay.
So that is what is happening in these conditions. Okay.
The reason why I'm saying this is I
Yeah.
read somewhere that continuous esophageal reflux can cause cancer. So, pre-cancer stage?
Okay. Well, I may have to read more on that to really refresh my mind, but what I know is that if GERD can lead to cancer, then it must be able to do so in addition to other factors, or in the presence of other factors. Okay. In and of itself alone may not, but when other factors are present in addition to the GERD, then there's a likelihood that cancerous condition may arise.
Okay.
Yeah. Anymore. So we now go to metaplasia. Metaplasia. And we are saying that metaplasia is the replacement of one type of tissue by another related to it on tissue origin. So one type of tissue or cell is replaced by another. So we've given examples here. It says it most often occurs in the epithelium of the mucous membranes. Epithelium, the mucous membranes. So for example, intestinal metaplasia of the gastric epithelium. Intestinal metaplasia of the gastric epithelium. Okay. So the intestines can be replaced by other cells or tissues. Okay. Then we have gastric metaplasia of intestinal. So they do changes. So the epithelium of the stomach can go and lie in the intestine. The one in the intestine can come and lie in the stomach. Okay. So that is how it is. Or squamous metaplasia of prismatic epithelium into stratified squamous epithelium. Okay. So metaplasia is simple. One tissue is replaced by another, or one cell is replaced by another when they are related to their origin. That is metaplasia. And we are saying that there are three types. You can have low-grade metaplasia, moderate-grade metaplasia, and then severe metaplasia. I've made a big mistake here. Okay, so that's fine. Forget about this one. Forget about this one. So that is metaplasia. Any question for me? Any question for me? Yes.
Okay, sir. So for the I think the question that Mr. David Deku asked about the dysplasia issue, about the, let me say, the acid reflux, and the research that I made and the article that I read was saying that for the dysplasia we have types and their location. So we have esophageal dysplasia, which is the Barrett esophagus. Related to your interest in esophageal stenosis, chronic acid reflux can cause the lining of the esophagus to develop dysplastic cells. Okay, so I continue to ask the machine that can acid reflux cause cancer or is a precancerous condition. So he said yes, chronic acid reflux can lead to precancerous condition. While occasional heartburn is common, frequent or long-term gastroesophageal reflux disease, which is the GERD, can cause cellular changes that increase the risk of cancer.
Yeah.
So the progression to cancer, the transition from acid reflux to cancer typically follows a specific sequence of tissue changes: chronic inflammation, esophagitis, rather, constant exposure to stomach acid irritate and damage the esophageal lining, and the Barrett esophagus. This is the primary precancerous conditions associated with reflux. To protect itself from acid, the body replaces normal esophageal cells with cells that resemble those in the intestines, which is the intestinal metaplasia. About 10 to 15 of people with chronic GERD develop Barrett esophagia, which is the precancerous something. So I think
Yeah.
it's
So
chronic acid cancer.
yeah. So we are not talking about cancer. We are talking about precancerous processes. Okay. So
Yes,
just as we are
precancerous.
saying, so just as we are saying, for GERD to be able to really cause cancer, it must happen in the presence of other factors. Okay, other factors. What GERD can do is that it can move to the severe dysplasia. Okay, just as we have here, it can move to severe dysplasia, which will cause precancerous processes, and the other factors will now shoot in to get this one going. Okay, so I think that is how it is. Okay.
But,
Yes.
but since it's a pre-cancerous stage, I think we should classify it as a dysplasia.
But then please come again.
Yes, I'm saying that since it's a pre-cancerous stage, it's a condition which leads to that. So since it's a pre-cancerous stage, I am thinking of it being a dysplasia. Or I'm wrong.
You are talking about the GERD. Okay.
Yes.
Yes. In that concept, it can be seen like that, but it is not the disease. It is not the disease. You know, what we are talking about here are adaptive mechanisms. Adaptive mechanisms. And probably diseases where we can see these adaptive mechanisms playing out there. Okay. So the disease itself is not an adaptive mechanism. Okay. Yes, GERD can enter into the severe forms, which that severe forms can predispose the person to precancerous processes. Precancerous processes are not cancer in itself, and sometimes You can get to precancerous processes and it ends there. It can never progress to cancer unless there's a presence of other factors. Okay, unless other factors come in, then cancer can now begin. That is what we are really saying. Any more questions?
Okay, sir.
Mm-hmm.
The metaplasia.
Mm-hmm.
Is it a case of the cells finding itself at another place, or there's a different cells? Okay, yes, the cells finding itself in another place. Is that a metaplasia?
We can put it that way.
Okay. Then are we going to classify endometriosis as metaplasia?
Endometriosis as metaplasia.
Yes.
Why do you think like that?
Okay, endometriosis is when the endometrial cells find themselves outside the uterus and perform or behave as if they are in the uterus.
Yeah. So I think I get you. Now for metaplasia, I think I get you. For metaplasia, the cells or tissue have an origin and they replace. So endometriosis has not really moved to another position. Okay, has not really moved to another position. It is staged where it is. The organ where it is attached to, that is where it is. You see, for example, we made mention of the gastric epithelium. Okay, gastric epithelium. So look at the stomach and look at the intestine. Then the epithelium in the stomach can go and attach themselves in the intestine, and the one in the intestine can come to the stomach. That is a typical metaplasia. Okay, but when the one that is in the stomach finds itself maybe on top of the stomach or at the back of the stomach, it is still the stomach. It may not qualify to be metaplasia.
All right.
Mm.
Thank you.
You're welcome. Any more questions, suggestion, contribution? Because we are done for today.
So a question.
Yes.
So for the metaplasia, the first one, I want you to please enlighten me on the mucous membranes.
Okay. So metaplasia, although it can happen in other, this one, research is still going on. But we are saying that metaplasia as an adaptive mechanism usually occurs in mucous membranes. You know mucus, what we call phlegms, what we call that you go and get medication and they will say, Coco, come and take medication. And the medication, it will let you go to the washroom, visit the washroom, you get all the phlegms away. Hey, the role the phlegms are playing in the body, you don't know. You want to get it away like that to be problem, So that is how it is. So these mucous membranes, okay, metaplasia usually happens then. So one mucous membrane goes and cover another part, okay, where there's supposed to be a mucous membrane, and another part mucous membrane can also travel to another part. That is what we are talking about. Okay, and you can understand how flames, they can move and all that. Yeah.
Sir.
Yes.
Please, I'm making an emphasis on the endometritis that my brother said about it.
Okay.
So you said the endometritis, it only happens in the uterus or the in endometrium. But here's the case. I read a certain article. It was saying that the tissues that forms within the endometrium can also, travel into the pelvic cavity. That is why normally some women feel, unpleasant pains within the pelvic region. So I don't know what about that one.
Yes. So that is another, this one on its own. It can be classified as a disease condition. Okay. What we are trying to say is that is there a condition, a situation where one tissue, okay, where a tissue is able to go and put the milk inside. So where there's a situation where there is one tissue or one a group of cells going to play a role in another part of the body, okay, other than where their origin is, although they are related. Okay, so just as you are talking about the stomach, it move from the stomach into the intestine, or from the intestine into the stomach. For endometriosis, we know that the origin is the uterus. The origin is the uterus, and then the cells, the tissue, overgrows. Okay, let me put it that way. Overgrows where it is, but it's still within the uterus. Now, in this aspect, if some part of the tissues are able to travel to another part, they are not going there to really replace another cell. They are going to cause trouble. Okay, they are going to cause trouble. So that one can be seen as a disease condition, and not necessarily that they are going to play a role to help that the woman in any way. Yes. Any more questions, suggestion, contribution? Go and put the milk in the fridge. It's not for you. It's not for you. Is it for you? Okay. Then, if there's no question, suggestion, contribution, then we'll call it a day. And then today I saw a name, Bill. I'm trying to see if I can recall. I think I saw Meshach. I've not seen him before. I see Okram. I see. Okay, so that's fine. So, is there any more questions, suggestion, contribution for me? Other than that, we'll call it a day. And God willing, same time tomorrow, we will meet. Bye-bye.
Thank you, sir.
Bye. Bye-bye.